talk about hepatic and biliary pathology. We're going to divide this lecture into cirrhosis, cholestatic diseases, hepatic inflammatory diseases, hepatic vascular diseases, and hepatic neoplasms. Let's first start off by talking about cirrhosis. The definition of cirrhosis is end-stage liver disease characterized by the disruption of the normal hepatic architecture by fibrosis. In other words, it's the scarring of the liver. Cirrhosis is the endpoint of most chronic liver diseases, including cholestatic liver diseases, inflammatory diseases such as hepatitis, and chronic hepatic vascular diseases. The fibrosis is stimulated by inflammation, which is mediated by cytokines, which signal collagen deposition. Wound healing. Fibrosis is part of the regenerative process after hepatocellular damage. And then there are other direct stimulators of fibrosis, including hepatitis B, carbon tetrachloride, and other chemicals. Portal hypertension is the result of increasing pressure in the portal venous system. This results in ascites, which results from increased hydrostatic pressure, splenomegaly, which results in thrombocytopenia, and esophageal varices, as well as caput medusae, and hemorrhoids, which result from the shunting of portal venous blood. Cirrhosis also results in jaundice, which is caused by the decreased clearance of bile, hepatic encephalopathy from the decreased clearance of ammonia, and estrogen excess, which results in spider angiomata, ulnar erythema, and testicular atrophy, as well as gynecomastia. With cirrhosis, you get decreased production of albumin, as well as various clotting factors, which result in a coagulopathy or an increased INR, which we'll discuss a little later. This slide summarizes all the features of cirrhosis, clinical features of cirrhosis, including jaundice, splenomegaly, esophageal varices, splenomegaly, peripheral edema, as well as bone marrow changes and testicular atrophy. This pathologic slide shows the changes found in cirrhosis, including the regenerative nodules, which you can see here in the pink and purple, as well as the dark bands of fibrosis which surround these nodules, which you can see here in the dark purple. This gross specimen shows the surface nodularity, which results from the chronic liver disease and fibrosis and regeneration. You can see that the liver is green because of the underlying cholestasis. Cirrhosis can also be characterized by morphology, in other words, micronodular cirrhosis or macronodular cirrhosis. Here you can see the various causes of micronodular cirrhosis, including alcoholic cirrhosis, metabolic liver disease, and cholestatic liver disease, as well as vascular liver disease. Macronodular cirrhosis really is due to causes such as viral hepatitis, but more often than not, things are mixed. Things that you'll be tested on the boards will include liver testing, including the so-called LFTs. This includes AST and ALT, which characterize hepatocyte injury. Most cases you'll see an AST greater than ALT in a 2-to-1 fashion, which usually indicates alcoholic hepatitis. Rarely will you ever see the AST greater than 300 in the case of alcoholic hepatitis. The ALK phos and GGT usually are elevated in cholestatic liver diseases. Bile may also be elevated as well in cholestatic liver diseases. Increases in direct bilirubin or conjugated bilirubin indicates defective excretion. Increases in the indirect or unconjugated bile usually indicates defective conjugation. The coagulation times, as we discussed before, can also be prolonged due to the decreased production of clotting factors. The serum total protein and albumin are also often low because remember the albumin and other proteins are synthesized in the liver. And serum ammonia may be high, as seen in hepatic encephalopathy in cirrhotics, due to the decreased clearance or metabolism of ammonia within the urea cycle. In this next section, we'll talk about cholestatic diseases. Cholestasis is defined as obstruction of the intra or extrahepatic bile ducts causing the accumulation of bile in the liver or in the blood. The etiology can be characterized as prehepatic, hepatic, or posthepatic. Usually we define intrahepatic cholestasis as a block of intrahepatic bile ducts due to drugs, pregnancy, or primary causes such as primary biliary cirrhosis. Extrahepatic cholestasis is usually the blockage of the common bile duct or the intrahepatic bile canaliculi. This being caused by extrahepatic biliary atresia, primary sclerosing cholangitis, bile duct injuries, or head of the pancreatic tumors. Choledocholithiasis, in other words gallstones, can also cause blockages in the bile duct. Primary biliary cirrhosis is an autoimmune disease characterized by positivity in AMA, that is the anti-mitochondrial antibodies. It usually causes a granulomatous destruction of the intrahepatic bile ducts. It progresses from chronic inflammation to frank cirrhosis in the later disease course. It's most often found in middle-aged women. So again, middle-aged women with a positive AMA, you should highly suspect primary biliary cirrhosis. Another disease, extrahepatic biliary atresia, is an inflammatory destruction of extrahepatic bile ducts in newborns. It causes a very severe neonatal jaundice and liver failure. It's the leading cause of liver transplantation in children. Again, this is a pediatric disease and is only found in children. Primary sclerosing cholangitis is an obliterative fibrosis of the intra or extrahepatic bile ducts, and sometimes can be seen in both. It causes a cholestasis and often leads to cirrhosis. This is a disease of young men, most oftenly, and is p-ANCA positive. It's associated with ulcerative colitis and increases the risk of cholangiocarcinoma. So again, on the boards, when you see a young male who presents with jaundice, who also has a history of inflammatory bowel disease, you should highly suspect primary sclerosing cholangitis. This is a picture of what primary sclerosing cholangitis looks like on a pathologic slide. Notice the onion skinning around the bile duct. This is a classic picture for primary sclerosing cholangitis. This is a cholangiogram showing primary sclerosing cholangitis. Notice the beating pattern of the bile ducts. Here you can see that there is a bead on a string-like pattern. Signs and symptoms associated with cholestatic disease include jaundice with pruritus, fat malabsorption, and fat-soluble vitamin deficiency due to the decreased bile excretion, skin xanthomas from decreased cholesterol excretion, and light-colored chalky stools, which usually indicates a deficiency of bile in the stool. The predominant lab findings are an increase in the direct bilirubin, an increase in the alk phos, and an increase in the cholesterol. In this next section, we'll talk about hereditary hyperbilirubinemias. These are not strictly cholestatic diseases, but rather genetic defects in bile metabolism. It's characterized by a mutation in bilirubin UGT, which usually causes an increase in indirect bilirubinemia. There are two other syndromes, Gilbert syndrome, which is a benign disorder and characterized by episodic jaundice under conditions of stress, such as fasting or illness. Again, this is a very common but benign condition. And Crigler-Najjar, which is a more severe defect, causing fatal kernicterus in type 1 or severe jaundice in type 2. There are other deficiencies in bile transport as well, which cause an increase in conjugated bile. Dubin-Johnson syndrome, which causes black pigmentation of the liver, but is otherwise clinically benign. Or Roeder syndrome, which is, again, another clinically benign syndrome without liver pigmentation. Here you can see a pathologic picture of Dubin-Johnson syndrome. Notice the abundant pigmentation in otherwise normal hepatocytes. This is the brown-like discoloration you see in the slide on the right. This concludes cirrhosis in the cholestatic disease section.